Welcome back to the Deep Dive. Today we're doing something a little bit different. We are basically turning this studio into a high-intensity revision hall.
Sounds serious.
It is. I've got a stack of the heavy hitters in front of me. We're talking Miller, Morgan, and Mikhail, Yao and Artuzio, all the latest guidelines. And we are tackling a topic that, it literally involves two lives in one procedure. We're talking obstetric anesthesia.
It is arguably the most high-stakes rotation you will do as a resident, and it's certainly one of the most critical topics for the final MD exams.
Right.
Look, if you mess up an answer on, say, a knee replacement, you might lose a few marks.
Yeah.
If you mess up the obstetric airway algorithm or the physiology of preeclampsia, you fail the exam. It's really that simple.
High stakes indeed. So for this deep dive, I want to role play a specific scenario.
Yeah.
I'm the final year MD resident, slightly panicked, staring down the barrel of the Gujarat University exam.
Okay.
And you're the senior MD anesthesia faculty. You're the examiner who's seen every single mistake a candidate could possibly make.
I have seen a few, yes.
Our mission is to take this mountain of literature and just synthesize it into a perfect 20-mark answer structure.
I accept the challenge. And frankly, if you can master obstetric anesthesia, you demonstrate a mastery of physiology, pharmacology, and crisis management all at once.
It covers everything.
It does. Standard anesthetic rules,
Yeah.
they often get turned upside down here.
Yeah.
You're dealing with altered physiology, a probable difficult airway, a full stomach, all while trying to keep a fetus happy. It's a whole different ballgame.
Okay, let's start right at the foundation then. Part A. I walk into the exam hall and I get that classic long answer question. Describe the physiological changes in pregnancy and their anesthetic implication.
The classic.
Or maybe I'm starting a case presentation. How do I frame the introduction so the examiner just sits up and knows, I mean business?
You start with the dual goals. That is your opening statement, your thesis.
Yeah.
You have to state that anesthesia in obstetrics is unique because we have two patients, the mother and the fetus.
Two patients.
Your primary goal is maternal safety, so that's maintaining her airway, her hemodynamic stability. Your secondary but totally simultaneous goal is fetal well-being.
Which means?
Avoiding drug-induced depression and, crucially, maintaining uteroplacental perfusion. If you don't mention two patients in that first minute, you've missed the entire philosophy of the subspecialty.
Two patients, one anesthetist. Got it.
And there's this one rule that seems to override everything else in the literature, something that dictates every single decision we make about the airway, the full stomach rule.
It is non-negotiable. You have to state this clearly. Every pregnant patient beyond the second trimester, so let's say roughly 18 to 20 weeks, is considered to have a full stomach.
Every single one.
Every single one. It does not matter if she's been fasting for 8 hours, 12 hours, 2 days. The rule stands.
Is that just because the uterus is physically pushing up on the stomach?
That's part of it, for sure, the mechanical displacement. But the real culprit is hormonal. It's
Yeah.
progesterone.
Progesterone. It relaxes smooth muscle all over the body to keep the uterus from contracting, right? But it also relaxes the lower esophageal sphincter, the LES.
So gatekeeper, the top of the stomach, is floppy.
Exactly. You have a relaxed gatekeeper and a stomach that's under pressure. That creates a permanent risk of aspiration.
Which brings us to Mendelssohn's syndrome.
Precisely. Acid aspiration pneumonitis. Because of this risk, your airway management is basically dictated for you. If you're doing a general anesthetic, it has to be a rapid sequence induction or RSI. Full stop.
No exceptions.
No exceptions. If you miss that point in an exam, if you even suggest a slow, gentle, mask-ventilated induction, you fail the question immediately. It's a safety critical point.
Okay, noted. Full stomach is absolute. Now, let's get to the meat of the answer, the physiological changes. This is usually the core of any long question, and I see cardiovascular changes highlighted everywhere as very high yield.
It's the engine of the whole answer, and you need to understand the numbers, not just the concepts. During pregnancy, the cardiac output, or CO, it increases significantly. We're talking about 40 to 50% above baseline.
That's huge.
It is, but you can't just say it goes up. To really impress the examiner, you need to describe the curve to show you understand the progression.
So it's not just a straight line up.
No, not at all. It rises in the first trimester, it then plateaus around 28 to 32 weeks, and then, and this is a classic Viva trap, it rises again during labor.
During labor itself. Why?
Every single uterine contraction squeezes about 300 to 500 mils of blood from the uteroplacental bed right back into the systemic circulation.
Like an autotransfusion.
That's exactly what it is. An autotransfusion with every contraction. So during active labor, cardiac output spikes by another 15 to 45%, depending on the pain and how strong the contractions are.
That is a massive, massive load on the heart. But the most critical moment is right after delivery, isn't it?
Immediately postpartum. That is the absolute danger zone. Once the baby is delivered and the placenta is out, the uterus contracts down hard. That eliminates the low-resistance placental circuit, and you get this huge autotransfusion of maybe a liter of blood back into the central circulation.
Yeah, a liter.
And on top of that, the caval compression, which we'll get to in a second, is suddenly relieved.
So the preload just skyrockets.
Cardiac output peaks right then. It can be 80% above pre-labor values. If a patient has any underlying cardiac disease like mitral stenosis or pulmonary hypertension, that is the moment they will go into heart failure. The heart suddenly has to handle a liter of extra volume.
Wow.
In an exam, if you're discussing cardiac disease and pregnancy, mentioning that specific postpartum peak is how you get the distinction marks.
Okay. So you mentioned caval compression. Let's talk about that. The supine hypotensive syndrome.
Or aortocaval compression. It's a fundamental concept. From about 20 weeks onwards, if the mother lies flat on her back, that heavy gravid uterus just sits on the inferior vena cava and squashes it against the vertebrae.
Which kills venous return.
Kills it, exactly. Venous return drops, cardiac output drops, blood pressure drops. But here is the real kicker for the fetus. Uterine blood flow is not auto-regulated.
What does that mean exactly? That the uterus can't dilate its own arteries to maintain flow if the pressure drops?
Precisely. It is 100% pressure dependent. So if mom's blood pressure drops, the baby's oxygen supply drops linearly and immediately. You might even see the fetal heart rate decelerate on the monitor before the mother even complains of feeling faint.
So the management implication here is just don't let them lie flat.
You never, ever anesthetize a pregnant woman supine. You always use a wedge under the right hip to tilt her 15 degrees to the left. This shifts the uterus off the IVC.
Always.
Always. In the exam, if you describe positioning for a C-section or even CPR without mentioning the wedge or manual displacement, you lose marks. It's that basic.
Okay, let's unpack the respiratory changes. I always think of this as the oxygen trap because it seems like everything is working against us during induction.
It is a very precarious balance. You have a supply and demand mismatch. First, the demand. Oxygen consumption is up by about 20 to 40%.
Why so much?
Because of the fetus, the placenta, and just the increased metabolic work of the mother, the engine is burning more fuel.
Right, but the fuel tank is smaller.
Exactly. The functional residual capacity, the FRC, which is your oxygen reserve, is decreased by 20%. That gravid uterus pushes the diaphragm upwards by about 4 centimeters, squashing the lungs.
So you have a smaller oxygen tank, the FRC, and a higher demand engine.
Which creates a very, very short apnea window. In a healthy non-pregnant patient, if you induce anesthesia and they stop breathing, you might have 6, maybe 8 minutes before they desaturate.
And in a pregnant patient?
You might have 2 to 3 minutes, maybe less. They desaturate incredibly fast.
That puts a huge amount of pressure on getting the tube in.
It does. And that is why pre-oxygenation is not just important, it's absolutely critical. You are racing against time. You have to denitrogenate the lungs completely to buy yourself as much time as possible.
And there's another concept here too. Closing capacity. Does that change?
That's a great point. The closing capacity itself, that's the lung volume at which the small airways start to collapse. It doesn't change much. But because the FRC decreases so much, the FRC can actually fall below the closing capacity, especially when the mother is lying down.
Which means airways are collapsing even during normal tidal breathing.
Yes. This leads to VQ mismatch and shunting, and that contributes to the rapid hypoxia. It's why pregnant women often have a lower PO2 just from lying flat.
Okay, and what about the airway anatomy itself? We hear difficult airway constantly in OB.
We call it capillary engorgement. The mucosa of the pharynx, the larynx, even the nasal passages, it becomes edematous and friable because of all the hormonal changes.
So it bleeds easily.
Very easily if you're rough. The glottic opening can be narrowed. So as a rule, we select a smaller endotracheal tube, a 6.0 or a 7.0 rather than the usual 7.5.
Got it. Smaller tube, gentle handling, pre-oxygen, like your life depends on it. What about the blood itself, the hematology?
2 key things, dilutional anemia and hypercoagulability. The plasma volume expands by about 45%, but the red blood cell mass only increases by 20%.
So the blood is thinner.
Exactly.
Yeah.
The hemoglobin concentration drops. A HB of 11 or 12 is considered normal. It's the physiological anemia of pregnancy.
It's a hemodilution.
Yes, but you shouldn't mistake it for a pathological anemia. This increased volume is actually a really important safety buffer against the hemorrhage that's expected at delivery.
And the clotting.
Pregnancy is a hypercoagulable state. Factors 7, 8, 9, 10, and fibrinogen all increase significantly. Fibrinogen can double.
Wow.
At the same time, antithrombin 3, a natural anticoagulant, decreases. Evolutionarily, this is to stop the mother from bleeding to death when the placenta detaches. But for us, it means a high risk of deep vein thrombosis and pulmonary embolism.
Which is why early ambulation and VTE prophylaxis are so important post-op. Okay, one more system. The central nervous system. This one always surprises me. The anesthetic requirement actually changes.
It does. The MAC, or minimum alveolar concentration for our volatile anesthetics, it decreases by about 30 to 40%.
So they go to sleep with less gas.
And they need less local anesthetic, too. This is crucial for your spinal and epidural dosing. In the epidural and spinal space, the veins, Batson's plexus are engorged because of that caval compression we talked about. The blood has to find an alternative route back to the heart.
And these swollen veins take up space?
Correct. They compress the dural sac, making the effective volume of the epidural and spinal spaces much smaller.
So if I inject the standard dose of a spinal drug that I'd give to a non-pregnant woman,
It'll shoot right up the spinal column. You'll get a high spinal or even a total spinal. You have to reduce your Neuroaxial doses by about 25 to 30% compared to a non-pregnant patient. That is a massive clinical pearl and a very frequent exam question.
okay, we have laid the foundation. Part A is done. Now let's move to Part B, anesthetic techniques. This is the exam core. So let's start with labor analgesia. If I'm asked to draw a diagram of the pain pathways, what am I drawing?
You need to distinguish between the two stages of labor because the pain comes from completely different places.
Okay.
In the first stage, that's cervical dilation and uterine contraction, the pain is visceral. It's a deep cramping pain. It travels via sympathetic nerve fibers that accompany the uterus.
And those enter the spinal cord
At T10, T11, T12, and L1. That's why the pain is felt in the lower abdomen and radiates to the lower back. Think T10 to L1.
Right, but then the baby starts to descend.
Yeah.
Second stage.
Exactly. In the second stage, the expulsion phase, the pain becomes somatic. It's sharp, localized pain. It's caused by the stretching of the vagina, the perineum, the pelvic floor.
And that signal travels somewhere else.
Yes, via the pudendal nerve. And that is S2, S3, and S4.
So a good labor epidural needs to cover both sets of dermatomes eventually.
Yes. Initially, you're targeting T10 to L1, but as labor progresses and she gets ready to deliver, you absolutely need that sacral spread to cover S2 to S4 for the delivery itself.
So what's the gold standard technique to do that?
The epidural, or the combined spinal epidural, the CSE, and the philosophy here is critical. You want analgesia, not anesthesia.
Analgesia, not anesthesia. Meaning?
We want to block the pain sensation that's carried by the small A delta and C fibers, but we want to spare the motor fibers, the big A alpha fibers. We want the mother to be able to push when the time comes.
So we use very, very dilute concentrations of local anesthetic.
Extremely dilute. For a surgical block, we might use 0.5% of bupivacaine. For labor analgesia, we're using like 0.625% or 0.125% bupivacaine, usually mixed with a lipid-soluble opioid like fentanyl.
The walking epidural.
That's what it's often called. Theoretically, the motor function is preserved enough to walk, though in practice, we usually keep them in bed for monitoring purposes.
Okay, tell me a bit more about the CSE technique. It seems to be the preferred method in a lot of centers now.
It really gives you the best of both worlds. You find the epidural space with your needle, then you pass a long, thin spinal needle through the epidural needle into the subarachnoid space.
A needle-through-needle technique.
Right. You inject a tiny dose of opioid or local anesthetic for immediate, powerful pain relief. That's the spinal component. Then you pull the spinal needle out and thread your epidural catheter for maintenance. It gives you the speed of a spinal with the flexibility and duration of an epidural.
That makes sense. Now, let's shift gears to the operating theater. Spinal anesthesia for a cesarean section. This has to be the most common anesthetic procedure in obstetrics. Why is it so preferred over general anesthesia?
In a word, safety. The airway is the biggest killer in obstetric anesthesia, period. A spinal avoids the airway entirely.
That's a huge plus.
It is. Plus, you minimize drug transfer to the fetus because you're using tiny doses in the spine rather than large systemic doses in the blood. And, just as importantly, the mother is awake to bond with the baby immediately.
But it's not without risks. The big one, the one we monitor like a hawk for, is hypotension.
Hypotension is the enemy. It happens because you're blocking the sympathetic chain from T4 downwards. This causes massive vasodilation in the legs and the gut venous pooling.
And you combine that with...
You combine that with the aortocaval compression we already talked about, and you can have a catastrophic drop in preload and in blood pressure.
So how do we manage it? This is a guaranteed Viva question, right? How do you prevent and treat postspinal hypotension?
It's a three-pronged attack. 1, left uterine displacement. Always. Non-negotiable. 2, fluids. We used to talk about preloading, giving fluids before the block. But the evidence now shows co-loading, giving fluids rapidly as the block is setting in, is more effective. A rapid bolus of crystalloids.
And 3, vasopressors. This is where the guidelines have shifted pretty significantly in the last decade, right? It used to be all about ephedrine.
Correct. For a long time, ephedrine was the classic choice. It increases heart rate, contractility. But we now know ephedrine crosses the placenta freely, and it stimulates fetal metabolism. It basically makes the fetus burn more energy in a low-flow state, which can lead to fetal acidosis.
So what's the new champion?
Phenylephrine. It's a pure alpha agonist. It raises maternal blood pressure by pure vasoconstriction. It crosses the placenta less, and even if it doesn't have that metabolic effect. It has a much better fetal safety profile in terms of pH.
So in the exam, if they ask for the vasopressor of choice, it is phenylephrine.
Without a moment's hesitation.
Okay. Now, what about the dreaded general anesthesia? If spinal is so great, when do we ever pull the trigger on GA?
Usually when time is absolutely critical or when a regional technique is contraindicated. The classic scenario is a Category 1 fetal distress, a true crash section.
Like a cord prolapse.
Exactly. A prolapsed cord, a severe prolonged deceleration. You need that baby out in minutes. You don't have 20 minutes to position and perform a spinal.
Or if the mother has a coagulopathy.
Right. If her platelets are very low, say below 75 or 80,000, putting a needle in her back risks an epidural hematoma, which can cause permanent paralysis. In that case, GA is much safer.
And the technique is strictly RSI.
Strict textbook RSI. Pre-oxygenate. Cricoid pressure. You apply firm pressure to the cricoid cartilage to occlude the esophagus. You induce with propofol or thiopentone. And for muscle relaxation.
Succinylcholine.
Succinylcholine or succinylcholine is the classic choice because it's fast on about 30 to 45 seconds and fast off. It has a very predictable profile.
What about high-dose rocuronium?
Yeah.
I see that used more often now, especially with Sugammadex available for reversal.
In modern practice, yes, 1.2 milligrams per kilo of rocuronium is an acceptable alternative, but only if you have Sugammadex immediately available for reversal. For the exam, unless you specifically state you have reversal available, succinylcholine remains the gold standard answer.
And the clock is ticking the whole time.
Absolutely. The key with GA is the incision to delivery time. The longer the mother is asleep, the more anesthetic drug crosses the placenta to the fetus. We want that baby out, ideally, within 3 to 5 minutes of induction. If it drags on, the baby comes out sleepy and needing resuscitation.
Let's move to Part C drugs. We've mentioned a few, but let's drill down. Local anesthetics. Bupivacaine seems to be the workhorse.
It is. Hyperbaric bupivacaine for spinals. It's dense, reliable, but you must remember cardiotoxicity. Pregnant hearts are more sensitive to bupivacaine toxicity, likely due to progesterone. It binds to cardiac sodium channels and is notoriously difficult to resuscitate.
Is that why we see ropivacaine used more often in labor epidurals?
Yes, that's a big part of it. Ropivacaine and levobupivacaine are pure S enantiomers. They have a much safer cardiac profile. They also offer better differential blockade, meaning they block sensory nerves more effectively than motor nerves. That's perfect for labor. You want the pain gone, but the leg's still working.
I want to touch on ion trapping. It's one of those concepts that always confuse me a bit, and I know examiners love to ask it to test your understanding of physiology.
Let's simplify it. The fetus is usually slightly more acidic than the mother. Its pH is a bit lower.
Okay.
Local anesthetics are weak bases. They cross the placenta in their unionized lipid-soluble form.
So the drug just drifts across the barrier.
Right. But once it hits the fetal blood, which is more acidic, it picks up a hydrogen ion. It becomes ionized. And ionized drugs are not lipid soluble. They cannot cross the lipid barrier back to the mother.
So they're trapped.
They are trapped, exactly. Now imagine a fetus that's in distress. It's hypoxic and acidotic. The pH drops even further. This creates a steeper gradient. The trap becomes like a volume, sucking more and more local anesthetic into the fetus and locking it there. This can lead to toxic levels in the newborn.
And this is why we worry about high doses of emetmide local anesthetics like lidocaine or mepivacaine, especially in fetal distress cases.
Correct. Chloroprocaine is an interesting exception because it's an ester. It is metabolized by plasma cholinesterase in the blood so rapidly, we're talking seconds, that practically zero drug ever reaches the fetus. It's a great rescue drug for rapidly extending an epidural for a C-section.
That makes perfect sense. Okay, uterotonics. The baby is out, the procedure is done, but the uterus is boggy and bleeding. Postpartum hemorrhage is looming. What's the drug protocol?
You need to have a hierarchy in your head. First line is always oxytocin or pitocin. But you have to be careful.
Why?
It causes smooth muscle relaxation in blood vessels. If you give it as a rapid IV bolus, it can cause profound hypotension and tachycardia. You must give it slowly or as an infusion.
Okay, so slow oxytocin first, if that fails.
Second line is often methylergometrine or methergine, but, and this is a huge red flag for exams, you cannot give methergine to a patient with preeclampsia or any kind of cardiac disease.
Why not?
It causes severe vasoconstriction and hypertension. It can cause a stroke in a preeclamptic woman. It's an absolute contraindication.
So for the hypertensive mom, methergine is strictly off the table. What's next?
Carboprost, or PGF2 alpha, also known as Hemabate. But what does prostaglandin F2 alpha do to smooth muscle? It contracts it. And that includes bronchial smooth muscle.
Ooh, so it causes bronchospasm.
It does. So it is absolutely contraindicated in asthmatics. If you give Carboprost to an asthmatic, you might stop the bleeding but start a life-threatening respiratory crisis.
Right. And finally, misoprostol.
Misoprostol, or PGE1. It's usually given rectally or sublingually. It's generally safe, it's stable, and it's a good adjunct. It can cause shivering and fever, but it doesn't have the severe hemodynamic contraindications of the others.
Okay, that brings us perfectly into Part D, obstetric emergencies. And let's start with a condition that basically defines high-risk obstetrics. Preeclampsia.
Preeclampsia is a multi-system disorder. You must not just think of it as high blood pressure. The underlying pathology is widespread endothelial damage and vasospasm.
So the blood vessels are damaged and clamped down.
Yes. And because of that, the patient is intravascularly dry. They have a depleted plasma volume. Even though they might look edematous and puffy, their vessels are leaky.
Anesthetically, what are our primary goals?
1. Control the blood pressure to prevent a hemorrhagic stroke. Our target is to keep the systolic below 160 and the diastolic below 110. 2. Prevent seizures, which is when it becomes eclampsia, and that's where magnesium sulfate comes in.
MgSO4. It's not an antihypertensive, is it? I remember getting corrected on that.
That's correct. It has some mild hypotensive effects, but that's not why we give it. It is a membrane stabilizer and a cerebral vasodilator that we use for seizure prophylaxis, but it has significant toxicity. It blocks neuromuscular transmission.
So how do we monitor for that toxicity?
Clinically, you watch the deep tendon reflexes, the knee jerk. If the reflexes disappear, that is your first major warning sign. Respiratory depression comes next, and then cardiac arrest follows.
And the antidote.
Calcium gluconate, 1 gram IV. You should have it in your pocket if you're managing a patient on a magnesium infusion.
Good tip.
Also, you have to remember that MgSO4 potentiates muscle relaxants. If you have to do a GA on a patient who's on magnesium, you need to drastically reduce your dose of non-depolarizing muscle relaxants like rocuronium.
What about the choice of anesthesia for a C-section in a patient with severe preeclampsia?
Students often think, oh, a spinal causes hypotension, and these patients have tight constricted vasculature, so a spinal must be dangerous. But actually, a spinal or an epidural is preferred.
Really? Why is that?
Because general anesthesia involves laryngoscopy and intubation, that stimulus causes a massive sympathetic surge. In a preeclamptic patient, that can spike the blood pressure to dangerously high levels, risking a stroke. A spinal provides a gradual, controlled reduction in BP, which can actually be beneficial. As long as the platelets are acceptable, Neuroaxial is the way to go.
But you have to be really careful with fluids, I imagine.
Absolutely. Because of that endothelial leak, these patients are very prone to pulmonary edema. You run them dry, restrict fluids to around 80 mL per hour, do not preload aggressively before your spinal.
Next emergency. Postpartum hemorrhage, PPH.
The killer. You have to remember the 4 T's. Tone, which is uterine atony and is the most common cause. Trauma, so tears and lacerations. Tissue, meaning retained placenta. And thrombin, a coagulopathy.
We discussed the drugs for tone. When do you pull the trigger on giving blood?
Early. If she's bleeding heavily, don't just pour in clear fluids like crystalloids or colloids. You will just dilute her clotting factors and make the bleeding worse. That's dilutional coagulopathy. You need to activate the massive transfusion protocol.
The 1.1.1 ratio.
Yes. 1 unit of packed red cells, 1 unit of fresh frozen plasma, 1 unit of platelets. You are trying to replace whole blood with whole blood components. And you must not forget tranexamic acid.
TXA.
The woman trial was a landmark study. It showed that giving TXA early, within 3 hours, significantly reduces mortality from bleeding.
Okay, one conceptual emergency that always seems to appear in exams. Amniotic fluid embolism, AFE.
AFE is terrifying. It presents as sudden cardiovascular collapse and hypoxia, often with the mother expressing a feeling of impending doom.
What's the mechanism?
It's not just a mechanical blockage like a clot. It's an anaphylactoid reaction to fetal debris hair, skin cells entering the maternal circulation. It causes severe pulmonary hypertension, right heart failure, and then a massive coagulopathy, or DIC.
How on earth do you manage that?
It's supportive care. There is no magic bullet. High-quality CPR, and remember to displace the uterus while you're doing chest compressions. If you don't tilt that uterus, your chest compressions are useless because there's no venous return.
Right, left uterine displacement even in a code.
Absolutely. You intubate, you support the circulation with massive doses of vasopressors. There is an AOK protocol mentioned in some modern texts, atropine, ondansetron, ketorolac. But the core of management is just aggressive, high-quality resuscitation.
Let's talk about the airway again. Specifically, the difficult airway algorithm in obstetrics.
The incidence of failed intubation is roughly 1 in 250 in obstetrics. In the general surgical population, it's more like 1 in 2,000.
That is a massive difference.
It's an order of magnitude higher.
And why is it so much harder?
It's the edema we talked about. Plus, large breasts can obstruct the laryngoscope handle insertion. Obesity is more common. And you have 0 time to mess around because of how fast they desaturate.
So walk me through the algorithm. Plan A is RSI.
Plan A, intubation. You maximize your position, get them ramped up, pre-oxygenate, induce. You take your best shot at intubation. If you fail, you do not keep trying and trying while the patient turns blue. You declare failed intubation.
And you move to Plan B.
Plan B is oxygenation. Your goal changes. You insert a supraglottic airway device, an SGA, like a second-generation LMA.
If the LMA works and you can ventilate, do you wake her up?
That's the critical decision point. If the fetus is in distress and you can ventilate effectively with the LMA, you often have to proceed with the surgery very carefully. You don't have time to wake her. If the fetus is fine or she can't ventilate well, you might wake her up and try a different approach later, like an awake technique.
And if you can't ventilate with the LMA, that's Plan C.
Plan C is an attempt at face mask ventilation. If that fails, you are in Plan D, CICO. Can't intubate, can't oxygenate.
That means?
That means you need a surgical airway, front of neck access, scalpel cricothyrotomy. You have to cut the neck to save the life.
Scary stuff. But knowing the steps saves lives. Okay, let's move to Part E, fetal and post-op considerations. We touched on drug transfer earlier.
The simple rules are lipid solubility, low molecular weight under 500 Daltons, and an unionized state all favor transfer across the placenta. So fentanyl crosses fast because it's lipid soluble. Morphine crosses slowly because it's water soluble.
But the biggest threat isn't usually the drug itself.
No. Practically speaking, the biggest threat to the fetus during anesthesia isn't the drug, it's maternal hypotension. If the placenta doesn't get blood flow, the baby doesn't get oxygen. End of story.
For post-op analgesia, we're moving towards a multimodal approach.
Definitely. Neuroaxial morphine, or Duramorph, given with the Spinal, is the gold standard. It can give 12 to 24 hours of excellent pain relief. But we always add paracetamol and NSAIDs around the clock.
Are NSAIDs safe? I thought they were bad for the baby.
That's a common confusion. After the umbilical cord is clamped, they are perfectly safe for the mother. Before delivery, NSAIDs can cause premature closure of the fetal ductus arteriosus, but for post-op pain in the mother, they are excellent and opioid-sparing.
What if you couldn't use neuroaxial morphine? Say, it was a GA case.
Then you should be thinking about a TAP block, a transversus abdominis plane block. It's an ultrasound-guided block that numbs the abdominal wall.
Wait, I just realized we skimmed over something that always trips people up. the specific nerves for these blocks? If I'm doing a tap block, what am I actually targeting?
That's a very good catch. For a tap block, you are depositing local anesthetic in the fascial plane between the internal oblique and the transversus abdominis muscles. This targets the anterior rami of nerves T7 to L1. It's fantastic for the somatic pain from the incision itself.
But does it cover the uterine cramping?
No, and that's the key limitation. It does not cover the visceral pain from the contracting uterus. That pain travels via the sympathetic chain, much deeper in the abdomen. That's why a tap block alone is not enough. You still need your multimodal approach with NSAIDs and paracetamol to handle the cramps.
Right, so the tap block fixes the cut, but not the cramp.
Exactly. And while we're on nerves, let's just clarify the pudendal nerve block. You might be asked about this for an instrumental delivery, like with forceps. The key landmark is the ischial spine. You inject near the ischial spine to block S2, S3, and S4.
Ischial spine. Got it. Okay, finally, Part F, exam integration. Let's go through some classic Viva traps. You already mentioned the Ephedrine versus Phenylephrine one. What about sedation for airway management?
Right. The examiner asks, the patient is struggling during an awake fiber optic intubation. What sedation do you give? The correct answer is none.
None. At all.
None. Sedation collapses the airway and depresses respiration. In an already difficult or obstructed airway, you want the patient breathing spontaneously. You use local anesthesia topicalization to numb the airway, not sedation to numb the brain. If you sedate them, you might lose the airway entirely and create a CICO scenario.
Another trap. Can you give a spinal in severe preeclampsia?
And so many students reflexively say, no, it causes hypotension. But the correct answer is yes, and in fact, it is the preferred technique. The hypotension is manageable and gradual, and it is much safer than risking a stroke from the hypertensive spike of a GA intubation.
And how should I structure my 20-mark theory answer to look really polished?
Structure is everything. Don't just vomit a list of facts. Start with your introduction, define the dual goals, state the full stomach rule,
Okay.
then physiology, draw a table, system on the left, then the change, then the anesthetic implication. It's clean and easy to read.
I like that.
Then discuss techniques. Labor analgesia first, distinguishing stage 1 from stage 2. Then C-section anesthesia, explaining why spinal is better than GA. Then drugs. Make sure you highlight the uterotonics and their specific contraindications. Then complications. PPH, preeclampsia, airway. And finally, a short conclusion summarizing the key safety principles.
What about diagrams?
Examiners love diagrams and flowcharts. You should be able to draw the cardiac output curves showing that postpartum peak. You should be able to draw the pain pathways, T10, L1 for stage 1, S2, S4 for stage 2. And you absolutely must be able to draw the difficult airway algorithm. If you can draw that algorithm correctly, you've basically passed that whole section.
This has been an absolutely incredible review. We've covered the physiology, the techniques, the drugs, and the disasters.
And it's a lot of information.
Yeah.
But you have to remember, in the exam, confidence really comes from understanding the why. If you understand why the FRC drops and why the cardiac output rises, then all the management steps become logical consequences. They aren't just a random list of facts you have to memorize.
2 patients, 1 anesthetist.
And always, always left uterine displacement.
Thank you so much for this. And to our listener, visualize those diagrams. Remember, the full stomach rule is absolute. And go crush that exam. You've got this.
Good luck.
We'll see you on next Deep Dive.